start to have painful contractions. And what you must remember is that for the woman, that is for her the start of labour. But if she's a first time mum, it's quite likely that she won't actually be going into labour, what we would consider properly, for some time. What midwives consider to be actual labour is 4 centimetres dilated, the cervix being 4 centimetres dilated onwards. But perceptions are, of course, for the woman, she's in labour from the start. And I would imagine that some anxious women, some nervous women, will probably call you when they're actually only just in labour. That's quite possible. So that's the first stage, when the cervix, because of the uterine contractions and because of, you know, the baby descending, that's when the cervix will open to what we call 10 centimetres. Obviously nobody's actually measuring that, but nominally 10 centimetres, so that the baby can pass through the cervix into the vagina and then be born. Okay? The pushing stage, which is often involuntary, is the second stage. And your baby is born, hopefully, kicking, screaming, etc. You can put baby onto mum's chest, and then all we've got to think about is the third stage, which is the placenta and membranes being expelled. Okay? So we're going to talk you through that sort of thing. So when you arrive, because I'm assuming you're arriving at a home birth, or you might be in Sainsbury's, or you might be, I don't know, anywhere, on the footpath somewhere, and some women go into very precipitate labour, that you will hear the woman making quite a lot of noise. Yeah? Sorry, I'm going to do some amateur dramatics here, but the woman will, if she's upright, which we normally recommend, she'll be kind of, that kind of noise is completely normal. Doesn't mean she's dying, just she's frightened because nobody's there. Yeah, she may feel like it. She's frightened because nobody's there. When you come, I think you have a big role to reassure her. Yeah? So what sort of thing might you want to say?
Introduce yourself. Hello. How are
Yeah,
you?
exactly.
We're going to be all right. Let's not worry. Let's get you on the ambulance out of everybody's eyes.
Yeah, absolutely. Privacy, dignity, we say, you know, cover her up if she's got everything on show, and tell her your name. Maybe, you know, even touch her. It's okay, I'm going to look after you. If I were you, I'd avoid everything's going to be all right, because we don't know. We can't promise.
No, of course.
I mean, to be honest, 99% of the time, everything will be all right, won't it? And particularly if it's a quick birth. The babies that arrive quickly normally want to be born, and they're kicking and screaming and everything. Okay? So please, remember those soft skills. Remember that I'm Sam, or whoever you are. I'm Charlotte, I'm Rose. I'm going to look after you. We're here. And the midwife's on her way. That's the good news. The midwife's on her way. We've called.
We don't really know what we're doing. The midwife's coming.
Well,
don't tell her that.
Again, I just want to make clear to you that this is a good symbiotic relationship, because I have been at births that start to go pear-shaped at home. I used to do lots of home births. We ring the ambulance, or Dad rings the ambulance, Grandma rings the ambulance. When you walk through the door, it's like, oh, thank God you're here. And I've also been on the other side, where I come to a BBA as a midwife, and the paramedics there going, oh, so pleased to see you. So we were explain what BBA is. Do you all know what BBA is? Yeah, it's their business, I think. So yeah. Okay, lovely. So shall we imagine we've come into, can I have a name for this lady, please?
Let's call her Lucy.
Lucy, nice name, Lucy. So you've come into Lucy's house, and
Wiggling.
it's Rose, isn't it? Oh yeah, she's got a tummy,
Anyway,
flabby tummy. Would you like to do your introduction to her?
Really?
Oh come on, yeah. I've done my silly round. You can do yours.
Why am I going first? It's not fair. Okay. Oh, jeez.
Do you want me to do it?
Just introduce
I'll do it if you're feeling nervous.
I don't
Don't
like
worry.
that.
That's fine. I'll do it. So, hi Lucy. I'm Kate. I'm from. What would you say? I'm a paramedic.
Yeah.
Right, yeah. I'm a paramedic. We're going to look after you now. You all right? That's okay. Yeah. Just calm down. Try and stay calm. We'll be fine. We'll be fine. Okay. And she's doing her all the time. Okay. Try and keep it calm. Yeah. Okay. Now, what would you want to do next? Or what would your colleague want to do? Because you normally come in twos, don't you?
Yeah.
What do you think would be important?
Check to see if the head's crowning.
Yeah, certainly. Can I just have a little look? Is that okay, Lucy? Just have a little look. Let's give you a towel, all right? Yeah, I think we'll take this off for the purposes of the camera, but you might do this.
Yeah.
There we go. Okay, yeah, do you know, I can see the top of your baby's head, you're going to be fine, yeah, everything. There you are, I've just said it, you're going to be fine. But that's the kind of thing, okay? And it is true that we call this the introitus, you do sometimes see a little bit of dark. I would say to you, be a bit careful, because sometimes you think you see the head, and it's actually maybe a bit of vaginal wall coming out of that, so don't excite her too soon.
Make sure you know what you're looking at.
I know it sounds, in a sense, scary. I've had paramedic students say to me before they'd much rather be a road traffic accident or somebody's jumped from 12th floor than come to a birth. Whereas for us, well, I don't know about you two, but I could not deal with any broken legs or worse, But it is a normal process, okay?
And sometimes instead of saying that we can see your baby's head, you could just say, oh, we're really starting to see things open up. If you're not quite sure, but just you can reassure her that we are seeing something, but you're just not quite sure what it is just yet.
And if you can't see anything, I guess for you guys, that is where you decide, are we going to stay at home or are we going to put her in the ambulance? Yeah. So you call it scoop and run, is that it? Do you still say that? And go in to, phone ahead presumably to labour ward, wherever your unit is, and tell them. So you're going to spend a little bit of time and see what's happening. Is she getting that involuntary urge to push? And if she is, you'll see it in her body. She'll be going, oh, and there's a bearing down. We sometimes say to women, you're getting that urge to bear down, and they'll say either a yes or no. If she's saying to you, oh, it's so good to see you, can I make you a cup of tea? She's probably in that. Do you remember I was talking about the first stage, second stage, third? She's probably in the first stage. It's probably not going to happen imminently. But if she's had children before, that cervix I was telling you about tends to sort of start off like that, and we've known it go from being just a little bit open to completely open in minutes. So you can never be sure. So the best thing is probably to open whatever equipment you've got. Something like this. These strange scissors are for cutting the cord. Is that showing up?
Have they got a special name? What's their...
Cord scissors.
Something like Latin or something.
Yeah, not as I know of. I mean, I don't know.
No, cord scissors.
Obviously you're familiar with forceps, and then they very kindly produced two
clips. I think we get the clips as well.
Cord clamps. Okay, and we clamp before we cut. So, I think you were going to get our baby coming back looking. Please join in, please.
Yeah, so whilst one colleague is assessing the lady to see how close delivery actually is, it would be actually quite good for the other paramedic or your colleague to look at her notes. To see, and the notes are quite good from all trusts. And there'll be like things in red if she's got any real compounding issues that might affect the delivery. Usually if they have the parents or whoever's there will be quite vocal, oh, by the way, I've got XYZ.
Or if you are a bit, oh, I don't know what's going on, just ask the woman, is anything major happened in your pregnancy? She will know, and it probably will be the first thing she will say if there has been something that's popped up in pregnancy.
Have your scans been all right? You might want to say, do you know your blood group? Do you know what we're interested in terms of blood groups?
If it's their first baby, it can something to do with, I can't remember the specific blood groups, but they can mix.
That's right.
Yeah.
Were you rhesus-negative, Charlotte? Oh, you're rhesus-negative
No,
now.
But
I mean, to be honest, there's nothing urgent that needs to be done because we've got 72 hours before she needs to. Well, she needs to have anti-D, or at least we recommend she has anti-D within 72 hours. Have you heard of anti-D?
Yeah.
Okay. Lovely. The reality is, if you come to a woman at home, just like you said, Sam, the likelihood is she'll be on the floor, she'll be in the bathroom, she might be leaning over the bath or the wash basin. She's very unlikely to be lying on a bed. Most women, left to their own devices, do not choose to lie down. Where's our pelvis? If you think about it, ideally you want gravity on your side. So,
camera.
sorry.
That's
Thank you. There's our pelvis, yeah. So symphysis pubis, this is your coccyx here. You really want to have gravity on your side, and the majority of women, in my experience, will choose to kneel. Some of them might lean, some of them might sort of stand and lean if they've got something to lean on. But I don't think I've ever gone to a home birth where a woman has been lying down, unless she's maybe in a latent phase, that's the early stage, or unless she's absolutely exhausted, which of course you do get exhausted, but you're uncomfortable on your back, because when you think about it, everything we haven't got, we've got the sacrum but not the coccyx, haven't we? So everything really is pushed together when you're lying down, whereas if you're kneeling up, you can let everything sort of open up. So, you know, if we wanted to speed things up as midwives, we'd probably get her to get gravity on her side. But for you arriving, not necessarily wanting everything to go too quickly, you'll be very happy if she's on her back. And you might even suggest, do you want to lie back? Give her some pillows so she's not totally flat. Girls, do you want to?
Yeah.
So these models are fairly new and not necessarily easy to deal with, but you can see that with every contraction, if I do a contraction noise, you'll see that the head comes forward. So, oh, it's coming, I can feel it between my legs. Oh my God, it's coming. And you'd be going, calm down, it's fine, everything's as it should be. Between the contractions, Lucy, I want you to try and just get some air, breathe deeply. And when I say to you, I want you to try not to push. You can blow, all right? You can just blow. That's it, Daisy, wonderful. The baby's head's coming nicely. Just blow for me slowly if you can. Now, notice Daisy's got her hands poised, but you don't actually have to do anything. If, like this, it looks like it's all happening nicely. Next contraction, just blow and do it gently. Good, well done, Lucy. Oh, there we are. There's your baby's head. Fantastic. Okay.
So at this point you would check for the chin to be delivered. They wouldn't, ideally, we want the baby to actually be born in that position.
It very often is. If the woman's on her back, you first see the baby's back of their head.
Yeah.
If the woman's kneeling up, so you're working with her bum,
their face.
you'll see the face.
Yeah.
Okay.
Then the baby's head will start to turn, which we call restitute, and it's kind of the baby getting into position to free the shoulders.
Yeah.
So,
And the mum will be, at this stage, obviously, they talk about like the ring of fire, because when the head is actually being born, it's stretching all the muscles of the perineum, and it is incredibly painful, but that's why it's important to tell them not to push, because if they push, you're risking tearing of the perineum.
Breathing.
That's why you breathe the baby out so it's controlled. So you need to get her partner or her birth partner on board and just say, you know, work on your breathing and watch. Yeah,
And if she's too quick, if she's like panicking,
Yeah.
say try and slow it down.
Yeah.
And you try and get your voice as calm as you can, so that she tries to be calm.
So how much of the head would you, or the crown of the head, would you expect to be protruding to know that the next contraction will probably be the full delivery? Is it only a little bit of the top, or is it
You'll
a
see
a
how
fair
much
amount?
is approaching,
Yeah.
don't
Yeah.
you? If it's a multip, someone who's had
It
a
could
baby
all
before,
happen
it can just be
like that.
right out.
Right, okay.
If it's a woman who's not had a baby before, everything is stretching for the first time, and so it could actually
actually
take a
be,
while.
it may actually be sort of a couple of contractions that she's actually just got to breathe, quite slowly through. Her natural instinct will be to push
It's
and
a
get that
sort
baby
of a
out.
reflex action, really.
Yeah.
and
So-
babies tend to rock, so
Yeah.
they will come down when she's pushing, and then they might come back a little bit. But when the baby gets to the point where it's not rocking back anymore, we kind of think, okay, this baby's head will probably be delivered
Is
quite
it when
soon.
you start to see the start of the head when you get them to stop pushing then?
No, wouldn't. I mean, play it by. You have to play it
When
by
you've got the
ear.
lot,
Should we try and get the baby back in to show you? Pull the baby out. Sorry, baby.
Just to show you with the pelvis here, this symphysis pubis, what happens when the baby is born is that, well, you'll see in the next session when it gets stuck like that. But what we're trying to do, the baby's head appears and then we call it restitutes. It turns so that the anterior shoulder, that's the shoulder nearest mum's front, comes out under the pubic arch, okay? But before that, Daisy and Sian are going to show you. We're seeing quite a lot of the head there. The vulva is gaping, and you know that baby's not far away. It's sitting right there, okay?
And with every contraction, you know, the baby's head will come
And it will
closer.
do that.
Yeah, that's what it will do. And every time it will just stay a little bit longer, so it will keep going.
And for
Keep
the
going,
mum,
keep
that's
going.
quite frustrating.
Yeah.
I can remember it now,
Keep
24
going.
years ago, going, oh, it keeps going in
That's it.
again.
Okay,
and
now
my
keep
midwife
going.
said, don't worry, it's absolutely right,
breathe.
it's stretching you. Yes?
Breathe for me. Slow deep breaths, keep going. And you'll find when she breathes, like the baby's head will just
It will come
it will
naturally.
just start coming. And it's just so we protect her underneath, because sometimes if the baby's head comes out, and that's why you're poised as well, because sometimes if the head shoots out, it can be quite damaging for the woman. That's it, just breathe. Well done. Baby's coming, baby's coming. That's it. That's it. And that's it. So you're looking for the chin to be free. So the chin is now free. Well done, your baby's head is now
The
delivered.
other thing, if I may say,
Yeah.
that some people worry about, and I'm going to have to improvise here, is when they see a bit of the cord. You have to just ignore this round the baby's neck. And in the old days, people used to say, oh, I had a terrible birth, the baby died, the cord was round the neck. But we know that actually it's often not a problem,
Yeah.
and you should not panic if you see the cord. If you can,
If it's loose
sometimes
enough.
you can loop it over the baby's head and the baby will be born, okay? This is the umbilical cord we're talking about. If you can't, just see how it progresses. Do not attempt to cut. Do not attempt to cut, okay? Normally the baby is going to sort itself out.
Yeah.
Yeah? But if it is loose enough, you might want to feel and just very gently loop it over. Okay?
So this next stage, the mother will be sort of really quite exhausted, because that is really, really hard work to deliver the head. So she'll be very exhausted. So whilst the baby is restituting, as we call it, it gives the mother time to catch her breath. It would be a good
Have a
idea.
drink of water,
yeah, have
maybe.
a drink of water or some Lucozade Sport or something like that.
Whatever she's
Just
on.
to have a little bit of rest, get cold compress on her head, you know, get the partner to do all of that.
Yeah, all the-
But it's just to sort of calm her down, because obviously she's still yet got to deliver the shoulders.
And I would probably
So-
say to her, your baby's head is born, that's the hardest bit. With the next contraction, I want you to push as hard as you can, and then the baby's body will be. So we're not doing any breathing or blowing for the body. We actually want the force to get that out.
Sometimes you might find that the baby's head comes out and then the shoulders
Yeah,
just follow.
it
just
all
follows.
Sometimes
happens.
it can happen.
So
with the
during restitution, the baby will rotate.
And,
Okay.
and the woman sometimes says, oh, it feels weird, the
Yeah.
baby's wriggling.
It's
you know.
because the baby's trying to get its shoulders into the widest part of the pelvis for delivery. Now the baby can rotate whichever way it wants to. So there's no sort of rhyme or reason which way they go. You just have to watch them to do it. So we're going to rotate the
Nature
baby
knows
this
what
way.
it's doing at this point.
Yeah.
You just
So it means that the shoulders are going into the widest part of the pelvis for delivery. So that's now fully restituted. As I say, it might all happen in one quick manoeuvre. Sometimes you'll get like a minute or so before the next
And then-
contraction.
under we go.
Also, with a normal baby, the head doesn't really do that. It's more like there is kind of sometimes room under. It's just because this baby's head's quite heavy.
Yeah.
Yeah.
So
Doesn't normally rest on the
Yeah.
on the bed or floor.
So you would kind of be able to just support
If
like
you-
that.
yeah.
Right.
And the actual manoeuvre that you deliver the baby is in axial traction.
So if you
So-
think of the spine, this baby doesn't have one, but if you think of the spine of the baby as being the axis, when we say axial traction, just gently a hand either side and you just go pretty much in the
And you
direction
follow
of the
the
spine.
direction of the spine. So you support.
So Daisy is supporting very gently, not clamping. And, oh, I've got another contraction coming!
Don't be afraid, baby's coming, baby's coming.
Oh, no! Oh my God! My uterus has
And
come
then,
out!
and then you go in the
Now I've got a
direction.
nice prolapsed vulva.
Oh,
The baby would still be attached, so that's something to be
oh
mindful
God, where's the
of.
placenta?
Because if you pull the baby up, sometimes they have short cords and we don't want them to snap.
How
So-
long is it usually between the head being delivered and the...
It seems like forever,
Yeah.
but when you think about it, how often is a woman having contractions? Do you know, roughly?
What, during the final stages?
Yeah. We'd expect
the 2
probably
minutes?
3 contractions in 10 minutes, maybe 4
Oh, okay.
at that stage. So if you think about it, it could be 3 minutes. And you might be getting twitchy, oh my God, do I have to pull the
While
baby
you're
out?
there with the head.
Do not, if the woman's all right and the baby's head looks all right, do not think about doing anything until she has a contraction. The contraction is the power that sends it through. It's a bit like trying to move in your car without turning the engine on. You can't, you know, you need the power to send it through. And that's what the contraction does.
So baby delivers and we'll bring baby up onto mum. Yes.
You can see the cord here's a little bit on the short side.
Yeah.
And let's get rid of the towel so it's skin
Yeah.
to skin,
Oh,
yeah?
yes.
Or are you going to wipe
Yeah,
the
there
baby
wouldn't
first?
really usually be a towel.
No, I just did that for a
Yeah.
bit of
Sheet.
dignity, yeah? But we can now,
Start
that's
drying
it.
the baby.
Put her up nicely.
Just start drying the baby.
And this is important, that we do stimulate the baby and we do dry it, because a baby that is wet is a baby that is cold. That's something else you might want to do. Make sure the windows are closed. Say to Dad, if Dad's around or whoever is around, could you make sure the radiators are on, if you've got them, have you got fire? You want it nice and warm for when the baby arrives. If it's a summer's day, summer's night, you know, it's kind of 20 degrees or above, absolutely no worry. We'd still probably close the window because you don't want a draft at this stage.
Yeah.
This is where you might put your little hat on if you want to.
Remove the wet towel
Yeah.
as soon as you've dried.
Yeah.
Remove the wet towel
Get a
and
new
put
one.
a new towel on.
Sometimes women's waters won't go until they deliver. So, you know, you might dry the baby and the towel might be soaked. So just make sure
Yeah.
you're swapping it. Make sure you're keeping the baby's head nice and dry as well. And hopefully the baby is screaming.
Don't be
screaming.
surprised as well. Sometimes at restitution, babies can be absolutely quiet and
Yeah,
won't
yeah.
take a breath. Other times, during restitution, they're starting to cry whilst the body is still inside the lady, and it can be a little bit like, you know,
Well, they
weird
open
the
their eyes
first time. They
sometimes.
open their eyes. They sometimes cry.
Yeah.
They start, you know, lip
So if the
smacking.
baby's just like sitting there...
That's
not
fine
really-
as
don't
well.
really drive with it, so-
They don't have to, but just don't be surprised. Not all babies, not all babies, you know, take their first breath once they're actually up onto their mum's tummy. Some actually do take their breath
Yeah.
when they're still the majoritively in utero.
Yeah.
So
So
think
Sean
that's wrong.
and Daisy have stimulated the baby with the towel. They've taken some of the blood and the gunge. Oh, the woman, by the way, is very likely to have pooed as well. Sorry to say this if you haven't had your breakfast. But when she's pushing, that involuntary pushing, the baby is also pressing against the rectum. And I'm sorry to say that is often a byproduct. So you might want an Inco pad under there and your orange bag ready. So that we kind of dispose of it without making a fuss, really. It may not be a very pleasant thought, but for us as midwives and for you at a birth, you'll be glad, because it means the baby is coming around the corner, as it were, around the bend, and is probably going to arrive soon. But the important thing I was going to say is, having stimulated the baby, dried the baby, blood, gunge, poo, the important thing is to swap towels.
Yeah.
So you'll be asking Dad or Grandma, could you please bring some towels? They don't have to be new, they don't actually even have to be clean, but they need to be dry. And if there's time, you could put them on that radiator to warm. That's always nice, isn't it? Sean, what were you worrying about?
no, I was just wondering, do they have to do APGARs?
Oh,
Yeah.
do you have to?
Yeah.
You do APGARs.
I was going to ask, when the baby's coming out, obviously if it takes its first breath and the body's still in utero, would you expect to see a colour change within the face and the perfusion to start while it's still there, or does that not really
Not
change?
necessarily
until it comes up? That's fine.
And we're not always that worried if the baby's a bit blue to
Yeah.
start with.
Yeah, no.
I mean,
Good
you do it.
stimulation and it will often respond. It's white that worries us, really.
Yeah, it's
more.
white.
Then you're looking at your NNR, your neonatal resuscitation, which
Yeah.
I assume you carry a bag of masks.
Yeah.
don't you?
Yeah.
Okay, that's another story,
That
isn't
sounds
it?
good.
And actually, when you do your APGARs at 1 minute, it's actually quite 1 minute is actually quite a
Yes,
long,
it
long
is.
time
Yeah.
It is.
before you actually have to fully assess that baby. So,
Do you remember what you're looking for?
Appearance, grimace.
Sorry?
Appearance, grimace,
Cries.
Okay, appearance, yeah. So grimace is, does it respond to your rubbing, your towel stimulation? What else are we looking at? Heart rate. So ideally, do you carry a stethoscope? Yep. So you'd be listening to the heart. What else?
but
are we
if that
looking
if
for?
that baby's screaming and crying, you know,
Yeah.
you know that
Yeah,
heart rate
exactly.
isn't a
Yeah,
problem.
exactly.
So you
So
don't
you don't
actually
need to
physically
worry.
have to listen
Yeah.
unless you've got a cause to listen.
We tend to do the APGARs as we go along. We don't sort of think, right, let's have this baby and do the APGARs. We just look at
Yeah.
the colour, we look at the response to our stimulus. As you say, if it's crying, we know the heart rate's going to be fine. What else are we looking
Colour.
for? I always
Colour,
forget the
yeah.
colour, yeah. It's,
Tone.
it's very rare that a baby is totally pink by 1 minute, so they're more likely to get 8 or 9 rather than 10. Would you agree?
Unless you're a neonatologist and gives them 10 at 1.
Yeah.
And then it's tone as well. So, you know, if you lift the arm, does it just flop down?
This baby
Or
would
is
not
it-
score well on tone.
Yeah, is it reacting to you touching the baby?
Yeah. Has it got some muscle control and things like that?
And as I say, the babies that you're going to come to, most of them will come out really kicking and screaming, in which case they're brilliant on their tone. Right, girls, so we changed the towel. I just went
Yeah,
to my
yeah.
bag because I thought I had a little baby's hat in it, but I've left it at home, unfortunately. So we put a hat on if we think that's necessary. Again, as I say, if it's a lovely sunny day, not necessarily.
Also, try and get her in, you know, a comfortable position.
Yeah.
If she has been kneeling, you know, kind of maybe get her to sit back so the baby's on her tummy, because, you know, it probably will be quite uncomfortable for her, and you don't know how long it will take for the placenta to come. So, you know, try and just get her in a bit more comfortable position. Maybe, you know, put a, just a towel like
Yeah.
there, just to.
And maybe sit her up a
Yeah.
bit more. So again, she's got gravity on her side now for the placenta and membranes to deliver. Congratulate her. You know, you've got a beautiful baby. You probably, what we normally do is not say what the gender is. We normally let mum and dad work that out for themselves. But, you know, that's up to you. They may know, they probably will know already. And the best thing then is for her to be skin to skin with the baby. And if she wants to put the baby on the breast, that's fantastic, because breastfeeding, one, is the absolute gold standard feeding method of choice, best for mum, best for baby. And the other thing is that the baby, if the baby does nuzzle or even actually feed, it increases the oxytocin, the hormone which has caused the contractions, and which will cause contractions again for the uterus to clamp down and expel this placenta. Okay, we know that the placenta is adhering to the wall of the uterus. So obviously after the baby's born, when the uterus starts to clamp down, it's going to mean that the placenta shears away and comes down the birth canal and ready to come out. Now there are two kinds, this is what we call the third stage of labour. Two kinds of third stage generally. One is one in hospitals. Very often we will give an intramuscular injection into the thigh, obviously with the woman's consent. This needs to be discussed preferably antenatally. Does she want a managed third stage or an active third stage, where we give an injection and then we help to deliver the placenta, which we'll explain in a minute? Or does she want a physiological, a normal third stage, where really it's just a matter of watching and waiting and encouraging her to be as upright as possible? She might even go to the loo at this point. If the blood loss is okay and you've got plenty of Inco pads, which I'm sure you do, you might say, you know, would you like to go and sit on the toilet? Because that way you're sitting upright, and you're more likely to have that gravity and the contractions. The contractions which you get after the baby's born are a bit like period pains. It's a sort of a nasty, sometimes worse than that, a nasty kind of grumbling pain of the uterus contracting down and getting rid of that placenta and membranes. And I think for you as paramedics, that second option is the best one, where you watch and wait, hoping the midwives are about to arrive. But obviously if the blood loss is severe, then you'll be thinking very much about giving your symptometrin, did you say? Or syntocinon?
Symptometrin, but you can't give text, no. But you can give conjunction.
In regards to the cord as well, it could be look quite white. That usually means that like all the blood has gone through the cord, or it could be like this, where it's like, you know, quite red. You see, the blood's still there. And keeping baby attached to the cord, if everything, you know, the blood loss is quite fine, is absolutely fine. You know, it's actually many benefits for the baby, keeping the baby attached to the cord. So if you don't have to clamp and cut, then don't worry. Sometimes you can just keep the baby attached, and the placenta can come out attached, all still attached. There's no concern with that. I was just thinking, if the baby was to come out with the cord around the neck, I was just going to show you what we usually do. Yeah.
Is there a stage with the placenta and stuff where you would think about cutting it before?
Yeah, if you've got a flat baby, if you've got a white baby that is
Floppy.
unresponsive and floppy, it would be best to, and you'll know once you've delivered that baby onto the tummy, sort of by that 1 minute, you'll know from doing your Apgar rhythms that baby is not good,
And all your stimulation. So we'd hope at this point, you know, I'm not doing it very well, but by come on baby, hello baby, and it starts to go, maybe spits up a bit of stuff, excuse me, and then starts to cry. You know that's fine. You can put baby on mum's tummy with a clean towel, not this one, and you can relax for a bit actually, because you really don't need to worry.
Yeah.
We have a question.
Yes, there's a question in the chat room.
Yes.
The question is, do we have to wait for the placenta to get delivered before clamping and cutting the cord, or just wait for the pulsation
To stop?
to end and the cord to become white, no matter if the placenta is delivered?
Right.
Okay.
If they're going to have a physiological third stage where we don't intervene with any drugs or anything like that, you don't clamp and
You
and
wait
cut.
for the cord to completely drain and it will go very grey. You can see there is no blood in it.
Yeah.
And then
It depends on the lady as well, because some ladies do actually want to deliver the placenta whilst it is still attached to the baby. So you don't have to clamp and cut. The normal procedure would be to clamp and cut, but if the woman doesn't want you to do that, then you don't have to. It's not gonna change anything. So if she's okay with it being clamped and cut, then obviously you would clamp, and what you would do is you would place
put it on because they're a devil
no,
to
I know.
undo.
You would actually place one of your little
Clips.
clamps, which I think you get, round the cord, and I would leave quite a length. We would probably go a little bit closer, but if it, leave as much length because it can be trimmed at a later stage. So you need to clamp it there.
You just press the clamp
Just
together.
press the
but
clamp.
just
I'm not
click
going
together.
to. 'cause
we're
you
not going to
can't-
do it because they're a devil to get off.
And that would be clamped, and then obviously ask the partner, wherever, if
They want
they
to
want
cut.
want to cut, and it's
I'm
cutting.
grandma, can I cut?
You certainly can.
Thank
and
you.
you'd be cutting in
Oh,
between.
it's very thick. It's like cutting big bacon gristle or
You get all types of cords, thin, tiny ones, great big fat ones, and they're covered in what's called Wortman's jelly. So it can be quite jelly-like, but they are quite tough. You do actually have to use a fair bit of force
If you move
to
it up,
actually.
we can pretend because there's a little thing here, isn't there?
Oh,
Yeah. So if I cut there, if you pull, Sean. Cut, 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 cut. Woo! There we are. So
and there will be a little bit of a spurt of blood because
So-
obviously between the two clamps there will be a little bit of blood in the cord. So
the-
baby's now free.
And then you can move baby up into a bit more of a comfortable position with mum, and then you kind of just leave the cord there. And if it is a physiological third stage, then we leave till the placenta comes out on its own, and you might start to see a little bit of a bleed, or you might start to see the placenta, and then it should just come away on its own.
the woman might say, "Oh, I can feel something. Something doesn't feel right. It's quite heavy. might feel something heavy in the vagina, and you might say, just give a little cough or a little push, and then we'll suddenly see. I'm only pulling now to show you. You wouldn't pull.
You don't
with
touch.
a physiological. Oh yeah, here's your placenta. Just bear down. Just bear down. You have your bowl, your kidney bowl or your sick bowl.
Or something to put
Are
it
there
in.
any sick bowls around? You know the cardboard ones. Hang on a sec. Or a kidney bowl. Lovely, perfect. That'll do. Any container like this will do. You'd put the end of the cord in there, and then if you want to, you can just ease it out. Push a little bit more, it doesn't hurt, there's no bones in. There we go, look, there's your placenta. That's been keeping your baby alive for the last 40 weeks.
Just be mindful as well. Some people do tend to do things with their placenta, so just don't like chuck it aside and then
It's
forget what it
actually
is.
their property.
Yeah.
So you need, at some point, no hurry, to ask the question, would you like us to take this away, or do you want to keep it? Some people like to bury it under their rose bush.
Turn
Some
it into
people
capsules.
turn it into capsules that are supposed to help with postnatal depression. Whether they're placebo or work, we don't know, but hey, you know, up to them.
Yeah.
It is the property
Yeah.
of the woman.
So the thing to really remember is if she's going for a physiological third stage, you just clamp and cut if that's what the woman wants, and leave well alone. Okay, and just watch it come down, and say, as Kate has said with the prompts, that if she says she can feel something or you can actually see the placenta on inspection, a little cough, a little push, and hopefully it will come away.
Can I just say that the clamping and cutting for physiological, so natural, is only when the cord has stopped pulsating.
Yeah.
Okay. Would you like us to do a managed third stage? So if you were worried about the blood loss, or if the woman says, just get this placenta out, I don't want to wait, I want to get showered and dressed and, you know.
So I've got just a quick question. Sorry,
Yeah, of
before we do
course.
that.
Okay.
So obviously you carry the drug that delivers the placenta quicker. Obviously
Yeah.
we don't carry that at all. And if you're not on scene, I'm sure assuming
In that case, you
Okay,
have
so
no
you don't need
choice.
to worry
It's
about it.
physiological.
You would
So
hope
that's
that
what
you
I
would
was
hope that
gonna
the
say.
midwife would be
Yeah.
there.
So
She's
if
got the drug
midwife
on it,
just doesn't
and she
turn up,
would
we are
take
just
over.
going to be waiting.
You
Yeah.
cannot go wrong as long as blood loss is okay, and we'll talk about that in a minute.
Yeah.
As long as blood loss is okay, you cannot go wrong by just watching and waiting.
How long, just as a query question then, how long, so say you guys do
It could
turn
be up
up.
to an hour.
No, but say you guys turn up, how
Yeah.
long can you then administer, can you administer that drug
Yeah,
any time
you can,
to deliver
yes.
it?
Yeah.
So there's nothing lost.
And you said up to an hour for the placenta to come after
Yeah.
the birth of the baby.
Yeah, and some women are just frightened because, you know, pushing the baby out has not been a walk in the park. They think it'll be the same for this. But look at the difference. This placenta is just floppy. It's like a piece of liver. So it doesn't hurt.
Yeah.
And we have to convince the woman that it's not going to hurt. Whereas, of course, the baby with a head, with a skull, with shoulders,
Yeah.
it's not too pleasant, you know.
And whilst that's being delivered, you can obviously, you know, just assess the baby, make sure baby's got a hat on,
Yeah.
make sure baby's, you know, head's covered, make sure baby's nice and dry, just whilst you're waiting, you know, for that to happen. And speak to the woman. Congratulations.
Would you like me to help you
Yeah.
to put baby on the breast? I mean, I guess that's not your forte, but at least
We
you
can
can
give it a go.
help. Yeah, you
Yeah.
can just put the baby's head near the breast and,
Yeah.
and encourage that. If she says, "Oh no, I'm not breastfeeding," oh well, just have a snuggle, just have a
Yeah.
cuddle with your baby. Skin to skin is good because even after the placenta is born, we want that oxytocin to be flowing. And if a mother feels maternal and has her baby skin to skin, that's when the oxytocin will flow. And she'll be starting to relax because you've done your job and baby's there, she's done her job. And so the oxytocin flowing will help the uterus to clamp down and the blood flow to stop.
I'm not quite sure if it's the same with you guys as well. You know, just noting the time the baby's born and
Yeah, we
things
do.
like that. Just so you know, even if you're doing this in your colleagues, just noting the time,
Yeah.
just the main times that you know
Like
baby's
on
born.
gloves, usual
Yeah.
thing.
Yes.
Yeah.
We know everything. If you don't know what the time down, you get in trouble.
Yeah,
Yeah,
exactly.
exactly,
So,
yeah.
So just noting, you know, what's happening when the baby's born. You know, what baby's coming out like, all things like that. Just so they can look back.
Yeah.
You know,
Yeah.
when the midwife comes, she can see what's
Yeah.
what's
just
happened.
things like head
Head.
delivered.
Yeah.
And when the full baby is delivered,
Yeah.
those two times, and obviously if the placenta gets delivered before the midwife arrives,
Yeah. What was that time?
that sort of thing.
So
So
it
those
could
are your
be
three.
head delivered or head born 10 o'clock, baby born 10:02 in good condition, crying, yeah, placenta and membranes 10:30, let's say. Very often a woman, the placenta has come away and it's sitting there, as I say, the woman's frightened to push it out, but sometimes you see signs, you see a little extra gush of blood, don't be afraid, it's just the placenta coming away. Or you'll notice that the cord lengthens, you know, suddenly there's more cord showing, and that shows that this is probably just sitting there in the vagina waiting to be pushed out. Okay. Would you like, I think it might be a good idea to do a managed third stage.
Is there any other questions?
Any other questions, Rob?
No, there's nothing with that. I know you talked about it. So these guys would normally do the APCAR score 30 seconds after, then 5 minutes after.
Oh, 1 minute.
30 and 5?
So I think they're immediately on delivery, and then 5 minutes.
This, no,
We normally do it at 1 minute, and at 5 there's not much point doing it at 30 seconds because
Okay, that's fine.
so much changes.
Have you talked about that? Because I know it came
We
up.
have.
yeah.
It probably
Fine.
won't,
Yeah.
So yeah, if you want to do the managed third stage,
Yeah, we haven't got a syringe around, have we? Just to pretend. Don't need a needle. Doesn't matter if not, we'll mime it.
I don't know. I'm going to do this.
Didn't know you were doing amateur dramatics today, did you?
I'm going to get one of them cups.
That's what you
Do you
wanted to
want,
do.
do you want a seat, girls? I mean, I'm sure we could manage a chair if you want it. No, you have to share it.
Shall I not
I'll do these one break.
got ready?
Do this and then we'll.
Well, no, because we're going to be putting
Yeah, no, let's
we're going to be putting those on, aren't we?
Yeah, let's just do it.
Oh, we did all right. Yeah.
Yeah, right.
Can you put in there?
I know.
Baby in there.
Put triplets in there.
Yeah, she's got quite a cavity, hasn't she? Poor thing.
Random question.
Yeah, go for it.
Multiple births.
Knows that all well.
Are we having a bit more of a...
Hopefully you're a bit higher.
more?
It's not a lot you can do,
Yeah,
isn't
no.
it?
Just you have to repeat the process.
Yeah.
That is literally it.
individual placenta?
It depends.
Sorry,
It
sir.
depends on the type of multiple birth.
So in the notes,
I
would it
think-
be documented
Yes.
as per the amount of placenta, etc.?
Yeah,
where-
I would.
for each
To be
baby, or-
honest, in that situation, I would
Yeah.
ask the woman. She will know
Yeah.
how many babies she's got, how many sacs there are,
Yeah.
and how many placentas there are.
Perfect.
So
But
you
if
could
I
have
were
one.
you,
Your
I'd
crew
be
member
more,
is
I'd be
continuously
more
calling the
keen to
midwife.
get in.
Yeah.
I think you would be urged to get into the
So what was the
hospital.
question?
Yeah.
Would
Yeah.
you ask?
Don't
I said
think
if
I
there
just
was
asked
imminent
not to
multiple
talk
birth.
over each other because the people on the other
Sorry.
end
Oh,
struggle,
okay.
so we could have it one person.
Okay.
Oh,
So,
sorry.
do you want to say what you're saying about?
Yeah, so, you know, at that point it would be with a multiple birth, it would be more about transfer into hospital, because by having a multiple birth you are increasing your risks. Okay, so if you arrive and you can't actually see the head,
You're going.
I'd go.
Yeah.
Because you're gonna have time. Depends obviously how far you are away from the hospital. But if you can't see the head, I would say that you've got a very good chance that you would probably be at a hospital
Yeah.
before the arrival of one of the twins, and hopefully or triplets or whatever. And hopefully what would then happen is that when you would arrive, you would have somebody from the maternity unit that would be coming down to meet you
Yeah.
when you arrive.
If one was there or one was imminent. and
If
we're
one
waiting
was
on the
there
others,
and one
you'd
was
stay.
one was imminent,
You'd
stay.
have to stay. Yeah.
One
Stay.
person looking after the woman who is birthing the baby. The other person, I would phone the labour ward, and they might send
someone
out a
Yeah.
flying squad to come and give you support, because
Yeah.
it is more complex, definitely.
Resistant if
If-
we stay anyway.
Sorry?
So if we decide that we're staying on scene, we call for assistance.
So
Yeah,
you'd
I mean, you'd
another-
expect the midwives to come,
But
but for twins, they might even send a doctor as well.
Yeah.
Yeah.
Not
The other thing to ask, especially with a multiple birth, is do you know the position of your babies?
Yeah.
Yeah.
Right.
So you need to know, is that first twin that's coming, is it a breech baby?
Yeah.
Or is it, and if it's in a normal position, just treat it as though it's a single baby.
Yeah,
Okay?
just concentrate
Just
on the
concentrate.
one
Don't
first.
don't even think about that it's a multiple, because by the time that you've delivered that first baby, there is going to be other assistance with
Yeah.
you.
Yeah.
No doubt about it.
Do you watch Call the Midwife?
Yes.
Oh, it's a great programme. But I mean, when you think about it, in those days, 60s, early 70s, they didn't do much scanning.
Yeah.
So women would be there, they'd have the baby, and it would be all congratulations and that.
There'd
And
be
then
another one.
she said, "Oh, I feel like I need to push." And the midwife goes, "That's fine. That's your placenta." and out comes another one.
Yeah.
So no big deal really, but we make a big deal of it nowadays, maternity
Yeah.
care does.
Yeah.
Anyway, we just want to show you a woman having a managed third stage. Maybe, you say you don't carry this, you don't carry symptometry.
So intervention?
Oh,
Yeah.
symptometry
Yeah.
we
You
do.
do.
But I don't think we're allowed to give it in the capacity that you do.
No, we don't.
So we can't give
We
it.
What
in
about
administer
if
it
she
for
was
postpartum
bleeding?
hemorrhage.
If
too
she was
much?
bleeding, then yes, we would give it
Okay,
obviously.
right.
so I think it's important that you know how much blood is okay, because women do bleed quite a
Yeah.
lot when they give
Yeah.
birth, don't
More
they?
than
Yeah.
500
Anything
mils?
anything over 500
Yeah.
mils is classed as a postpartum hemorrhage.
Yeah.
Just for your own sort of mindset, I always try and think of blood loss as like a can of drink.
Yeah.
So I've always got in my mind that I know roughly what 330 mils of Coke looks like. So I try and equate what I'm seeing visually to like, would that
If you
fill
were
up,
to spill
if
a
you were
can
to
of
spill a
something
can
on
of
top.
Coke, would it be roughly the same?
So if that's your Inco pad,
Yeah.
what would you expect to see for a normal blood loss?
It
I would
certainly
say
wouldn't
a
be
good
covered.
patch.
A good,
No,
a
yeah,
good,
yeah.
a good
Is
patch.
fine, okay?
If that was sodden,
If it's coming all over
Yeah.
the Inco pad, you've got to change it, like literally over the edges.
yeah.
You might think, do you know, I think I'd like to give this woman the injection. And then you have to act, so let's imagine we've got this Inco pad here, and you're worried because, as I am,
That's right,
the
I'm going to deliver the
symptometry.
placenta.
I'll just throw it. Can you give symptometry IV as well?
You can, yes,
don't know
but
how
you
we can-
wouldn't.
Yeah.
Sit
You
the
wouldn't.
IM.
We want to do it
Right.
IM, and it's 5
Is that
international
TXA
units,
is
isn't it?
IV?
Symptometry.
Yeah.
TXA is IV.
Okay.
So what's the?
Well, this is much quicker, isn't
Yeah,
it?
just looking up. Sorry, go ahead.
This is quicker, and you have a little vial, and it's 5 international units.
Right. Okay.
So you draw it up, probably not in a large syringe like this, and you say to the woman, "Are you okay if I give you the injection? We just want to get the placenta out quickly because you're losing a bit of blood, and we'd like that to stop. Is that all right, Lucy?"
Yep, that's fine.
That's fine. So I'm going to into the thigh, draw it up, make sure there's no blood, and then in, and then we wait. Okay?
How long?
You, sorry?
How long do you reckon the time frame is?
Couple of
I know
minutes,
that's
something
minutes.
like that.
Question, but I'm
And what
asking
you
it.
normally see again is you see the cord lengthening. And again, you might see a little bit more of a gush. Not a big gush, but you see a little bit more. Oh, look, that cord's lengthening. Okay, do you want to show
Yeah.
which way that?
No, I can do it. Yes, you've got
So-
there's the scissors. We've got the.
What do we do there, Kat? Did I put them over here? Have you got them? No. Might need to.
That's all right. Should we just? So you'd clamp and cut baby's cord
could
like
use
we
a
did
forceps.
before.
Yeah. So
Um,
baby's now free.
So we've got the thing, and where's our little? We just have a receptacle here,
So you'd have one
like that. It would be
one
blue.
clamp would be on this end.
So you I do. You attach the clamp onto
the
here.
cord.
So it's
Then it, for the purposes of
down.
the camera,
You see.
let me just.
Oh, I think they can see on the.
Yeah.
yeah.
Okay.
Okay.
How long would you leave it before doing that? After giving the
think we'll do
Definitely allow for,
Yeah.
because what we do is delayed cord clamping. So you can definitely it's ideal to leave it at least a minute, but then you probably would have had that minute because you would then be noticing that she's still bleeding
Yeah.
quite a lot. So as long as you've had a minute go past to allow the blood to go into the baby before you actually separate the
'Cause we-
baby from the from the
Where's
placenta.
the placenta gone?
So
I've seen it, of course.
So what you're going to do is, I put my fingers here, so I've got the clamp in my hand. You want to guard the uterus as well, because if you're pulling, sometimes if you're not guarding, the uterus can come down with the placenta. Yeah. So you want to guard the uterus, and you want to just not too hard, just gently.
Just
So you're just prising.
You're kind of easing it out, really. I'm afraid the way the model is, we're
Yeah.
going to get complete prolapse.
And
There
you
we
can
go.
say to
Here
the
it
woman,
is.
if you can give a little push if you can, or a little cough. And that will happen. Sometimes as well, you can move the clamps
Pop off.
up a bit more, up here.
You obviously wouldn't do this normally. This
It's
is
just
just the mannequin.
Then you just
Oh,
gently
No,
pull.
It takes 3 people to get the placenta out.
It doesn't usually.
it doesn't, honestly.
This
we
is
do it
because
in
we
the
haven't
bit
we
more
haven't
building.
lubed it actually, have we?
Just put it.
Yeah. Other way.
So
Baby's born.
yeah. So you're just gonna gently prise. Yeah.
Yeah.
and then the placenta will just kind of come
Plop
out into
into
here.
the bowl.
Right.
And the woman usually goes, oh,
Yeah.
that feels better. Don't ask me why, but they just feel more normal then.
Like big heavy mass laying
Yeah.
at the bottom.
Yeah.
It's
Exactly.
literally just like liver.
And sometimes it is just sitting in the vagina, so it can be quite heavy. And then as soon as it comes out, it's kind of like, and it usually kind of just all kind of like follows after, and you should kind of see it all come out. And then that's it really.
Hopefully bleeding should stop.
Yeah. The one thing what you don't want to do is to pull too hard,
Yeah.
too quick, because you don't want the membranes to separate from
Yeah.
the main body of the placenta and then leave membranes inside, because that's going to cause her all sorts of problems. So it's controlled cord traction, okay? And again, if you're documenting, you will need to put that the placenta was delivered through controlled cord traction.
Centimetry in 5 international units was given, and then placenta and membranes delivered by control cord
What is
traction.
So symptometrin for us is contraindicated prior to the baby being born. We give it intramuscularly.
How
To
many?
cease.
We wouldn't do it
Stages.
prior to the baby being
No,
born.
No.
We'd do
Once
it
the baby's been
afterwards.
delivered,
Yeah.
we would do it afterwards.
But let's hope the majority of cases you'll be doing a physiological.
And also
process.
with, you know, the pulling of the cord, also not to pull too hard, because sometimes they can snap.
Snap.
And then if it snaps, it's harder to deliver the
I think the
placenta.
majority of paramedics are pretty much just leave it.
Definitely.
Exactly, yeah, and it's
But I did
yeah.
hear stories once of paramedics being told to get a shoelace and cut and tie the cord with a shoelace. Absolutely not. You know, you really, I know. I mean, in an emergency, it wouldn't be so awful. Some people use dental floss or embroidery silk, but you know, there's no need. No need.
But what you usually would do is, you know, just kind of leave it.
Leave, yeah,
Hands
that's
off.
what I'll-
Hands off, because sometimes if you touch the cord too much as well, it can spasm. So, you know, just try and
When in
Leave
doubt,
the tape.
hands off. And I
Yeah.
think that's we'll certainly be teaching you that for the breech birth.
Yeah.
But really, in the old days, women used to birth on their own. A lot of the interfering is not particularly productive. I think the soft skills are really important. Come on, you're fine. Try and stay calm. Don't scream. Screaming doesn't help you to have a baby. I mean, it's fine for women to make a noise, but it's better if the noise kind of goes down and goes towards pushing the baby out. So rather than a high-pitched scream where the air goes out, more of a sort of noise is more useful, really.
And sometimes just getting on the same level as the woman. So she's on the floor. Hi, my name is.
Yeah.
You know, just
Eye
so,
contact.
just so she can see who you are, and you can say, you know, just okay, big deep breaths, and it can really help remain their focus.
Absolutely.
Okay, so just, it's not so much a question, but it's just to give you an idea maybe what paramedics are faced with. So one of our students was on a call where 111 had told the family to tie the cord with a shoelace, 10 centimetres.
See?
The family then pulled the cord
Oh.
and caused a massive postpartum
Oh, no.
hemorrhage.
Oh.
She nearly died. So that's kind of what we sometimes
You
face in
poor
pre-hospital
guys
care.
being faced with that. That's horrible.
That's
So-
bad advice from 111.
Absolutely. Listen to us, not listen.
Most of their
That's
advice
awful.
is bad.
So I guess there you'd be looking at profuse and life-endangering blood loss, and you know what to do with that, don't you? And get her in as soon as you can, ringing ahead to the hospital to say what's coming in, I guess.
Okay, so we're just going to take a break there. So guys online, we're just going to pause. At 10:30, we're going to reconvene with the second part of this. If you guys online want to take half an hour, we'll see you back at 10:30.
Can you move the maths or something?
We can pause the recording. Okay.
Just quickly.